This is going to be the surface anatomy of the lateral aspect of the foot. First, we're going to look at the distal fibula, and then just posterior is the peroneal tendons. Posterior to that is the lateral aspect of the Achilles tendon. And then in between, you have the sural nerve. If the ankle and foot is in an inverted position, the branches of the peroneal nerve can be felt by running fingers across the lateral aspect of the ankle. It exits by the fibula tip and divides into two branches. This is the general location. So the lateral aspect of the fifth metatarsal head is indicated by the circle. Anterior process of the calcaneus is palpatable. Calcaneal and cuboid joint and cuboid bone. And then just anterior, the subtila joint. So the anterior aspect of the ankle is the tibialis anterior tendon and inserts into the medial cuneiform, medial eminence of the greater toe. The bump overlying the joint of the first metatarsal base, and the EHL tendon, as seen, is the IP joint in the big toe. The saphenous vein can be seen here. The medial malalis is the medial aspect of the ankle. Posterior tibial tendon can be seen if you invert the foot and is the small ridge. Flexor digitorum longus tendon is not palpatable, but the tibial artery is palpable and runs halfway between the Achilles tendon and the posterior tib tendon. So you want to have the patient lie down and bend knees. First, you want to palpate the ligaments to see if there's any tenderness. And then you can do an anterior drawer test, which can be done by drawing the foot in an anterior position. So go ahead and extend your leg. And look at the other side to see if there's a difference. You can assess CFL by a forced inversion, and they will let you know if they have any pain, and assess the talar dome and palpate the fifth metatarsal. So you want to work your way anteriorly, and the patient should report if they have any tenderness. Look at the fifth metatarsal to see if there's any possible fracture. If there is a high-grade ankle sprain, you can test syndesmosis damage by externally rotating the foot. And you can also test it by squeezing the tibia and fibula together. For Achilles tendinopathy, you can palpate the tendon, feel for swelling or pain, and can assess either side of the Achilles tendon to see if there's a bursa. If there is a defect, we can test for flexion and extension. If there is an Achilles rupture, you can do two tests with the patient on their belly. So you can squeeze, and the test should result in a plantar flexion of the foot. If there is an absence of this movement, it could indicate a rupture. Another way to assess is to check in dorsiflexion and how the foot falls off of the table. So forced dorsiflexion. For the Morton's neuroma is known as Mulder's click. You can elicit pain by just trying to click the foot to see if there's any pain. For a stress fracture of the second metatarsal, you can try palpating it. If they have any pain, that could indicate a stress fracture. The most common cause of heel pain could be plantar fasciitis. The first way to test there would be a tendon origin, would be a positive test if there's pain in this area, and pain and hyperextension of the big toe. So if we put their toe into hyperextension, they should have pain if they have plantar fasciitis. And then hallux valgus, by a deformity in their big toe, you can do range of motion in the big toe to see if they have any pain.